We'll be starting in just a moment. Okay, my name is Jason Moore, and it is my pleasure to introduce Matt Smith from Central Florida. And Matt, since we're starting a moment late, I'll let you just jump right into it.
Okay. You guys hear me all right? So my name is Matt Smith. I am a physiatrist. For those of you who don't know what that is, it's kind of a combination between sports medicine and neurology a little bit, and I did a little extra training in sports and spine. I do a lot of procedures for the spine. My clinic is called the Spine Health Institute. It's in Altamont Springs, Florida, which is just north of Orlando. I hear there's an Altamont around California, but that's not that one. All right, so the title of my talk is called More Than Bones, and the reason it's called that is because as a spine doc, most of my training and focus is on the bony part of the spine. My premise or thesis is that we're missing a lot of the spine when that's all that we concentrate on. So we're going to start off actually with a quote or a couple quotes. So this is one of my favorite authors, Nassim Taleb. I heard there's a rumor he might be here tomorrow. I don't know if that's true or not. Anyway, he's famously known for saying that you shouldn't quote people, but I'm quoting him, and it's from his book of aphorisms, the Bed of Procrustes, and it's modernity's double punishment is to both make us age prematurely and to live longer, and then we're all a bunch of contrarians, and Oscar Wilde, I think, shares some of that same spirit, and of course he's famous for saying everything popular is wrong. So one of my contrarian viewpoints is the way we look at spine as a medical profession, maybe, if not wrong, incomplete. So I'm going to pretend that we're all clinicians here, and I'm going to give you a patient presentation. So history of present illness. We have the typical gentleman that I might see in clinic, 45-year-old guy. He's coming in with low back pain around his right butt. Past medical history, he's got insulin-resistant diabetes mellitus, a little bit of sleep apnea, reflux. He's got some arthritis in other areas, a little psoriasis, maybe a little hypercholesterolemic. The social history, fairly clean-living guy. He likes to eat the standard American diet. Functional history, more or less the same, doesn't exercise quite as much as he should. Review of systems, nothing too scary. When I say scary, I'm thinking infection and cancer, right? So I'm thinking pain that awakens you at night, unintentional weight loss, things like that. Nothing too scary. Vitals, he's a little overweight. He's not a weightlifter. This is not because he can squat 500 pounds. He's just a little fat. From his physical exam, kind of an average build, what you would kind of expect from your everyday guy. So get some x-rays, nothing too scary. We think this might be a little bit of sacroiliac joint problem, which we think probably happens maybe up to 15% of the time. How do you treat him? I get him into physical therapy, give him a little bit of ibuprofen, maybe a sacroiliac joint belt, maybe do an injection if he's refractory to all this stuff. You know, your kind of standard stuff. So I've done that, but have I fixed the problem? Let's look at another patient. So similar 45-year-old guy. This time he doesn't come in with butt pain, but he comes in with hand pain. He's got some red, kind of painful nodules on his finger. He's got a history of mitral valve prolapse, tooth decay. He's diabetic too. He's got all those same kind of standard things that we see in almost everybody. This is a picture of his hand. So he's got, I decided not to shave, so this little sticker's not sticking on me. Anyway, so tell me if you can't hear me. So he's got these little nodules. Now these are actually, right here, these are not painful, but he's got ones on his fingertips that are. So what do we say? Well, you got little painful things on your hands. Having pain's bad. Let's give you some things to fix that pain. Just don't use your hands so much, right? And we fix the problem. Well, no, we haven't. Because at least these things here are called Janeway lesions. The things on his fingertips are called Osler nodes. These are septic emboli from what's called bacterial endocarditis, which is where you get an infection in your heart valve, shoots out little bits of bacteria that get lodged in little capillaries in your fingers, and you're basically on the you're on your way to dying really fast. And so if I just treated this guy, I've missed this whole underlying pathophysiology of what's really going on. I've only treated the symptoms. My contention is that treating that guy's sacroiliac pain is very similar to treating this guy's endocarditis with just a little bit of NSAIDs. I'm only treating the symptoms of a much deeper pathology. And so for those of you who don't know the lingo, supratentorial is your cortex, and that's kind of medical lingo for saying if your problem's supratentorial, it's saying it's all in your brain. So there's a reason probably a lot of our back pain patients come to us, and it's not just because they're crazy, right? There's more than just a psychological reason. They come with a whole constellation of pain symptoms and other problems. And then a doc I know quoted Bill Davis, and he said, just fixing these symptoms is like fixing a leaky faucet when your whole house is on fire. So how did I get started? This is actually a picture of me when I was 19. This is adriamycin. I'm a cancer survivor. I had a football-sized Ewing sarcoma in my belly. And they always say you don't know what you have until you don't have it. I was a mediocre athlete. I was pretty active and whatnot, but it wasn't until this happened that I said, I'm going to start working out. I'm going to really get into that lifestyle that really values everything that I can do. Of course, this is like late 90s. Paleo wasn't around then. This whole kind of thing wasn't around then, but I discovered actually all that when I was in residency. But this is kind of what got me going. So I'm going to talk about two things in this talk. The first is kind of stuff you guys already know or at least already suspect, at least in regards to low back pain. It's not just due to mechanical pathology, but also a manifestation of the metabolic syndrome. And if you don't know what that is, I'll talk about it. And the second part is the best way to fix the bulk of low back pain, or at least address it, this chronic low back pain, which is the main thing I'm going to focus on, is to address the metabolic syndrome in addition to the mechanics, such as what Esther speaks about. And I'm going to talk about this with 7 parts. And I'll just get going it now. So some perspective, we all know this is a gigantic problem. And how big of a problem is this? Well, in the world, there's a prevalence of about 70% low back pain. About anywhere, the incidence is thought to be about 5%, probably more. In the United States, we lose about 150 million work days a year because of low back pain. The direct cost is about $70 billion a year, indirect about $130 billion. This is old. So James Steele, I don't know if you guys have seen any of his talks, and he goes into this much better than I do, but as far as how this has been prevalent probably since the beginning of time. We know Otzi, the caveman, he has spondylosis. Spondylosis is arthritis of the spine, but this is also new. There's tons of evidence coming out now that says it's getting worse, and it's getting worse faster than it used to. One study in Sweden in the 80s saw a 4-fold increase. Now there's probably confounding variables such as insurance reimbursement and stuff like that for having low back pain, but it looks like more people are getting it. So it's a big, big bad thing. As a spine doc, some of the common things that I see and that I think about from a bony perspective at least are some of these. This is just a schematic of what your bones look like. This is where your belly would be, and this is, when you feel those ridges, you're feeling, these are called spinous processes. Your cord comes down here, ends about here, and the rest of that is as a string of nerves that look like a horse's tail. We call that the cauda equina. Here's your disc. The inner jelly part, called the nucleus pulposus, is the consistency of toothpaste, and the outer part is a tough fibrous ring. And then each bone individually, it looks like a tripod, where the big front leg is right here is where the disc and the bone is, and then you have these little 2 back legs called the facets at the end. So the relatively straightforward bony parts. So this is a cross-sectional or axial view of an MRI, and so you can see there's a disc bulge right here, okay? Here's that cauda equina, or that horse's tail. Here's those facets, and here's a disc bulge. Now, this typically presents with chronic low back pain. If it's pinching a nerve, you might find it going down your leg, but this can be chronic. I mean, usually it's acute, but it can be chronic, and it can cause focal low back pain in addition to shooting pain. Here's it from a sagittal or side view. You see that disc coming out. Here's that cauda equina right here. Compression fractures usually also present with acute pain, but you can have chronic pain with it. Here's one of my patients, L1 compression fracture. We number our spine bones. Yet the low back bones, you typically have 5. We start counting below the lowest rib of where the low back bones. And so this is the first one. You see how that's smushed. This is a 3D reconstruction of this CAT scan. You can see how it's smushed a little bit. So this is crazy. Talk about red flags. This is a gentleman I saw probably only about a month and a half ago. This right here is an abscess. He was parking cars and noted about 3 months of low back pain. He was parking cars the day before he came into the hospital. He started having low back pain, then he lost control of his bowel and bladder. We ended up having to do what's called a laminectomy, where you take the back part of the bone. My partner did this. I'm not a surgeon, I'm a physiatrist, but my partner took out the back part of his bone here and up top and ran a catheter and had to wash that whole thing out. So those are some of the more straightforward things. You see that on MRI, you kind of know what you got, all right? These are the trickier things, and now we have mechanical low back pain, which is what almost everybody has most of the time, which is your sinews, your tendons, your muscle strains. It's a lot harder to put your finger on what is exactly causing the pain. Now, we talked about a disc herniation causing pain. There's something called intervertebral disc disruption. A guy that I actually met last week, Nikolai Bogduk, describes this as not just disc degeneration. You talk about those rings of fibers. You can get tears in those. This is a real hard thing to diagnose. This is, you can put dye inside the disc and then get a CAT scan later, and it has a certain characteristic pattern that is suggestive of this. When you look at MRI, it looks real bright on a particular type of way you can look at it. We talked about the back being a three-pronged little stool maybe on each level, the facet joints being the back two levels. Here's a little arthritis, or this is what the facet joint looks like on axial view. Here's a CAT scan. You can see it a little bit better. See how there's a little arthritis there? I see this all the time. That can definitely be a source of chronic low back pain. I want to touch on an idea, though, which is, and we'll go into this in a lot more detail in just a second, but there's this idea that there's a progression that goes from a little bit of degeneration to instability to stability. And all of these parts of the low back pain kind of complex, or the disc and the facets and all these other things might play into that, but then we might eventually at some point come to stability. So, let's go and look about how MRIs can be a little misleading. So there's something called spondylosis deformans. Spondylosis means back not looking quite as perfect as it should. That's all it means. Spondylosis means, spondy means backbone, losis means something's up with it. So spondylosis, you get it as you age. Like I said, Otzi the caveman had it. But it seems that something else is going on more than just the normal wear and tear as we age. This is a patient, and if you're not used to looking at MRIs, you might not pick this up, but you should, even if you're not used to looking at them. This is not a normal looking back. This is one of my favorite patients. He's a great guy. He only has a little bit of pain radiating down his leg. He's been oystering. He's been doing all this stuff. Here's his cauda equina bunched up here. He's got numerous discs that are just getting worn out. This one's almost completely fused on its own. This one too. It looks horrible. His back looks awful, but he doesn't have that much pain. Here's a study that was done in 2013. They looked at about 170 guys in Sweden, and they looked at their two lowest disc levels. And they looked at all these different changes. You don't have to know what these mean, but basically they're a variety of things we might see on MRI. You have to have at least two of these. All right, here's a couple examples. This is called a modic change. This is at your lowest disc. This is swelling. We see it bright on this kind of MRI, dark on here. Here's that little high intensity zone right here. That might indicate a little bit of a tear within the disc. Here's what we call a type 2 modic change. That's where the bones around the disc get a little fattier. And here's a disc bulge. So I looked at all these problems on the MRI, all these things. Patients come to me, oh my God, I have degenerative disc disease. It's like some horrible thing. This is degenerative disc disease. This is spondylosis. This is all this. They looked at all this. They put it into this complicated algorithm, and they compared it to what's called an Oswestry Disability Index, is a measure of function, and your visual analog scale, which is a measure of pain. And what did they find as the correlation? As my old attending used to say, nothing much. So despite a progressive worsening of the people's back, there's not a good correlation with pain. Here's another study that looked at younger people. They did one MRI on a bunch of guys up to about 55 years of age, and then another one 12 months later. There was really no correlation with how bad their MRI looked and how bad their pain was. Furthermore, 13 of those guys 1 year later developed back pain in that interval. On their MRI follow-up, there was no change. So something's going on that we're not seeing on MRI. Here's another study. This is even weirder. So we talk about maybe there's not a one-to-one correlation. There might be a negative correlation. In this study, it showed that with older individuals, that the least degenerated disc had the most correlation with low back pain, and the most degenerated disc had the least correlation with low back pain. So this brings us then back to the Kirkcaldy-Willis cascade. Kirkcaldy-Willis is actually one guy, William Kirkcaldy-Willis. He came up with this in the 70s. So is maybe something going on? Are these guys stabilizing now? They're degenerating even more into where their pain's improving? Maybe. Or are we maybe not looking at all the same stuff or all the right stuff that we should? So we talked about that one study that looked at all these variables. When we look at everything, are we missing the one important thing that we should be looking at? Such as, for instance, high intensity zones. If I look at facet arthropathy and disc degeneration and all this other stuff, and I miss that point that there's a little bit of a T2 hyperintensity on your disc, by looking at everything else, am I clouding the signal? Or are we not looking at something? Because after all, this talk is called More Than Bones, and I've only talked about bones so far, so I might be alluding to something I'm talking about later. So let's talk real quick about what we tend to do for most low back pain. There's 4 treatments. Surgery, you can give injections. I'm sure you guys have heard of like epidurals and things like that. You can give drugs, and then I'm kind of clumping everything else that we do as far as a physical modality into physical therapy. This is called dynamic spondylolisthesis. This needs surgery. If you're bending forward and leaning back and your bones are actually shifting a good bit, you really probably need to get that fused. That's not much of a controversy. And there's a variety of things you can do for an injection. This actually comes with a lot of controversy too. A lot of times these are better for acute back pain, like an acute disc herniation. But sometimes you can do a few percutaneous image-guided procedures that get people up and going and that have a useful place. But certainly some of these things, including surgery, might be overdone. And then, of course, there's drugs. Strangely, the way we dose drugs and the way we choose what to give are based on the World Health Organization's prescription for how we should dose drugs for cancer patients, essentially. But we use that same thing for people with low back pain. And what are the results is that we get a lot of people who are taking Dilaudid and a lot of high-dose opioids for low back pain. And there's physical therapy, which is one of those things that can sometimes mean anything to everyone. It could be something like what Esther is prescribing. It could also be you go to the physical therapist and they get you doing an arm cycle ergometer for low back pain, and no one ever gets better. But we're going to talk more about this later. So I'm going to have a little bit of a segue now. I'm going to talk about one of my patients, and I'm not violating HIPAA because he let me use this. He said I could use his name, and his name's Tony. 71-year-old guy. He's about 73 now, but he has a pacemaker. He's got a little bit of intermittent low back pain, but no red flags, no neurologic deficit. And this is a picture of him. And he comes to me. I never had anybody say this to me. He goes, I want you to help me out. I got a little bit of low back pain, and I'm going to Ecuador to train with my Sherpa because I'm then going to go to Everest. All right? So he's 71 years old. He takes off his shirt for the physical exam. He looks like he's about 35 and a really healthy 35. He's neurologically intact. There's no red flags. A little social history. He's a businessman. He doesn't have any real bad habits. He's completed the Boston Marathon, and he's the oldest guy to complete the Antarctic Ice Marathon with a pacemaker. His CT, I'm not going to read you all this, but basically it's not great. And so here's a picture of it. Here's a disc bulge, gigantic disc bulge, worn out disc. This is called the vacuum phenomenon. It means the disc is worn out. He's got facet arthropathy. His back is not good. At least the bony parts aren't. But look at this. These are some muscles around the back. Those are really good. Here's the psoas muscles. These are your muscles that make you do that. Really good. So we ended up doing a little bit of conservative treatment. He hiked for 20 days on Everest. He said he was going over a crevasse. As he was crossing it, he felt a little twinge. He felt that he could probably go to the top, but he got a little paranoid, and so he stopped. But here's a guy with a pacemaker with a really jacked up looking spine climbing Everest. How is it even possible? Is it his genes? Is it his anatomy? Or is there something else going on? And so let's revisit anatomy and physiology a little bit. And this brings us to the perennial question: why do pigs have less back pain than humans? Well, here's an axial picture of an MRI around the lumbosacral junction. Here, I flipped it over for comparison purposes. Here's your extensor muscles right here. Here's your psoas muscles. This is one of my patients. And here's a pork chop that I cooked not too long ago in curry and coconut. This is a protein waffle that we made, and this is a plantain right here. And so this is gluten-free. I don't want to get crucified. But anyway, so I actually don't know if pigs have less back pain than humans. I'm not a veterinarian. But look at this one, the anatomy is totally different. But look at the spinous process. It's way unfair. Pigs are also quadrupeds. There's a lot going on here. But look how big, and these muscles are big and delicious. And that's, when you compare them to here, the pig has better muscles. And we know from some research in the past that strengthening of certain muscles looks like it can probably help low back pain. So I talked about the psoas muscles. That's your hip flexor muscles. It starts kind of like in the front part of your low back and then attaches right over here to your hip. We know that strengthening those tends to help chronic low back pain. Strengthening of the multifidus muscles, which are some of the muscles that help the spine extend, also seems to help. And then, of course, having weak ones is then correlated with back pain. But it's a little more subtle than that. So it looks like muscle asymmetry, almost more than anything, is associated with back pain on that side. And that's what this study showed in 2004 in the Journal of Spine. This is a study that was done in Australian football players, which I guess is soccer, where there's this muscle called the transversus abdominis. It's one of your corset muscles. If you wear a corset when you're working out, it's that same kind of muscle that helps you hold up your abdomen. And